And we're going to take you now into what I think is important, which is the real world of work. We've heard, really from the time of the Hippocratic Oath, this notion of we should do no harm. The Swiss cheese is a delightfully easy way of explaining to people the problems with protocols, barriers, training and supervision. We all struggle with issues around that. And then there's something that Liam and Bruce both touched upon, which is the notion of a conversation, a narrative, moving from the quantitative into the qualitative. How do we get to a place where we start to have conversations about our dirty linen? How do we start to talk about the mistakes that we inevitably make, driven by various pressures? How do we find a form of language that avoids people being frightened of talking about the things that go wrong? How do we move from the whole science of risk, which can seem very confusing to people, to just the notion that the IHI coaches us in, which is just to look at harm, just to look at the way we behave that leads to harm occurring to patients? Because unavoidable harm, unavoidable deaths, needless, these are the sorts of concepts that I've found particularly appealing, and they're the kind of concepts that have actually been very easy to translate to a clinical audience. So this presentation is to introduce you to a model so we can really begin to understand why it is clinicians are driven away from doing what they know in their heads to be the right thing to do. Why is it that our cognitive map of the world, based on all the evidence that we read, all of the things that we're told in seminars, why doesn't that translate into the behaviour, the things that we do? And if you think about it for a minute, when we're creating policy, we usually do it in the context of a closed room with a number of very expert, thoughtful people who can absolutely work out in their minds what the safe way of doing things should look like. But translate that out into the real world of work, and we'll have a conversation with you in the next 20 minutes about how able we are to translate the policy we write, based on evidence, into the practice that we actually deliver. And when you think about it, if we want to generate a conversation, there is a real problem between elements and organizations that believe the system is safe because we've written nice policy, and the folk who do the day job who understand that it's rarely possible to follow the policy to the letter as it is written. So Amalberti very helpfully produced a model which seems to me to engage clinicians very readily in debate. How many of you have driven in the last week? Lovely. Anybody gone over the speed limit? Lovely. Anybody been sent on a speed awareness course? Fantastic. Anybody just get a kicking? In other words, 3 points and a healthy fine? You're a very open audience. The notion that we get things wrong in our private lives, when you've all read the highway code, you've all taken a driving test, you've all seen the images on television of what happens to kids when they're hit at 20, 30 or 40 miles an hour. What drives you to go over the speed limit? How do you make the decision to take the risk? Do you even think about it? How many of you consciously decide, I'm going to speed now? I don't do that. Excellent. Perfect. You are so, so valuable to the model I'm about to articulate to you. Okay. Hold these guys in mind when it comes to the never-never zone. Okay. The idea here is that we are basically given a policy or a protocol. Drive at 70 if you're on the motorway, drive at 30 if you're in town. But the reality is there are a series of pressures operating on us that continually drive us to break the rules. And for many of us, what happens is we come out of what the Americans call the green zone. You'll see that beautifully we have the green zone circled in red, but I can't do the PowerPoint well enough to change that. And many of us find ourselves driving somewhere between 70 and 75. Usually we've heard that dinner party myth that the police speed cameras are only good for an error of 10%, therefore, anywhere up to 77, we're probably going to get away with it. Besides, you don't lose your license unless you're going over the ton. Let's just carry on. How many of you have been doing 75 in the outside lane and had folk coming up behind you with their lights on? Yeah, screaming, yeah, there we go. So there's another bunch of people out there who actually think it would be reasonable to go even a wee bit faster. How many of you have had a significant car crash? Okay. Did it change your driving? Yeah? Yeah. So you can see just on a show of hands, even in this room, that the proportion of people driving, the proportion of people driving fast and driving a wee bit faster than that, quite high. But thankfully, the number of crashes that prevent people from being in this room are actually quite low. And this is the first tyranny. This is the tyranny of small numbers. Bad things don't happen often enough to drive your practice back towards the green zone. And then we've got our friends down the front who consciously decide to speed because they're in the fast lane of life. They're the highly productive people. They're the folk who've got ahead because, let's face it, going faster at life and not having a crash is accruing you personal benefit. It may be that you're the person out in clinic who gets more patients seen than anybody else. You may be running a list that gets more people through than anybody else. You get to work on time. You get to more meetings. There are a whole series of personal advantages that come from being the kind of person that does this fast. But this, potentially, I think you would all agree, are the people driving over 100 regularly, and this is unsafe space. Things are going to go wrong. Now, I just want you to think about that in relation to our medical culture. So the Amalberti model runs through the same thing. I'll go through it again just so that we've got this in mind before we invite John to give us some examples of real-world practice. Here is the legal expected safe space of action as defined by professional standards. So the Royal Colleges, various other organizations that describe what we need to do, the things we set in policy nationally and in our hospitals. But the pressure of work, waiting list initiatives, getting the job done fast, very quickly means that the reality of real work is mostly out here, in this illegal normal space. And I think we all know colleagues who get away with it without having that car wreck, and then thankfully, few of us at all have these accidents, but what we're hearing between the 1 in 10 million and the 1 in 300 is, regrettably, health is having a heck of a sight more accident than airlines. What are we going to do to avoid people driving towards the unsafe space in their clinical practice? The never-never zone. We really do not want people getting here. So there are one or two things that line up with these. Here's policies, protocols, and regulation all about the green zone, or this very safe space, written in quiet rooms by elegant and intellectually able people. And here's real life, where I would argue most of us work. And
so let's see how that stacks up in a very simple situation that all of us face every day in our workplace. And that is the thing about which we all have policies and procedures: washing our hands. Very basic. And all organisations and the Department of Health itself has a policy for hand washing. Is it clear? Does everybody in your organisation know what your policy for hand washing and hand hygiene is? Do they know whether they have to use the hand gel as they walk into the ward? Do they have to wash their hands as they arrive in the ward? Do they have to wash their hands immediately before they touch a patient? Do they have to wash them again afterwards? Do they have to have the sleeves rolled up or short sleeves, tie tucked in, rings off, watches off? What exactly is the policy? If you asked 5 people, would they be able to tell you exactly what your policy is in your hospital? Would they all get the same? Would you get the same answer from all 5? Do you individually observe it? We all like to think that we do, but circumstances sometimes force us, or we feel they force us, to do something slightly different. And we may make a decision before we see a patient whether we wash our hands or not, or we may not even make that decision. We may just do the action without thinking about it. But we may actually choose, on certain occasions, to violate what we know is a hospital and indeed a national policy. And is there a limit beyond which we will not go? Do we know what the actual borderline is that takes us into the never zone? So let's look at that diagram again in relation to hand washing. We have a policy set. As Peter says, it's been thought up, carefully laid out, and people, let's assume, have been trained and know what it is. But in the real world, there are a number of pressures brought to bear that may push us to a varying extent outside the green zone. And first of all, there are pressures which mainly relate to time. And the first pressure on us and on our junior staff and our nursing staff is the pressure to get things done in an increasingly busy world. And in relation to that, there is the ease with which we allow people to do the action. How easy is it to find the hand washing materials? Is there a sink at that end of the ward? Is it at the other end of the ward? Is the gel available on the end of the bed? So how easy do we make it to actually do it? So there's pressure. There's secondly, people's perceived vulnerability. And we have to accept, first of all, that that varies. Some people will feel more vulnerable than others. Some people have a higher risk acceptance than others. And bearing on that, there is the vulnerability that comes from knowing what will happen to us if we do something wrong. And firstly, will we actually be caught out and punished? Will someone speak to me, embarrass me, or even discipline me if I don't? And secondly, what will actually happen if I don't? What's my belief system as to the validity of this rule? Unfortunately, with hand washing, the distance between cause and effect is very great. So although we may intellectually know that not washing our hands is a dangerous thing to do, the distance between cause and effect makes that vulnerability, a sense of vulnerability, quite low in this particular aspect. But that belief may be bolstered by what the culture around us is. And if there's a very strong culture of hand washing and great peer pressure, then our belief system will be bolstered and we will be much more likely to take the hand, to wash our hands. And that may vary in different parts of the hospital. In theatres, for instance, there is a ritualised hand washing, and it would be very difficult to break that culture. In the neonatal intensive care unit, the nurses and other staff will put great pressure on us to wash our hands, and we will certainly feel vulnerable if we don't. But in a general ward situation, it may be quite easy to get away with not doing it, and no one will notice or no one will say anything. So the combination of these pressures, vulnerability and beliefs and culture will push us in different situations a different distance outside the green zone into the various unsafe zones and possibly occasionally into the never zone. And it's easy to take an example where you are unintentionally pushed into a dangerous situation. Called to a patient in the evening, asked by your boss, for instance, to check what's in the drain at 10 o'clock tonight in order to decide whether to remove it. And the patient's had an operation, but his MRI say positive. You should gown, wash your hands, glove, but you're actually under pressure. The patient's waiting in the emergency department, so I'm not going to actually touch the patient. I'm just going to nip in and look at the drain. So I'll just quickly check it and go back to the ED, but the nurse has just asked me to go and write up night sedation for another patient in the ward, so I'll just quickly go to his bed and do that. And, oh, doc, my wound's a bit sore. Well, I'll just have a quick look. No, it's fine. So you've been pushed by pressure, by lack of peer pressure, into the dangerous zone. And that can happen so easily. And we can all think of examples of policies which we know to a varying extent and which we fail to regularly apply. Now, we were going to ask you to do a short table exercise here to think about those, but we're pushed for time, so we'll merely point out that nearly every policy is easily broken, and we all know of examples where it happens. Safety in the health service has been compared to the airline industry, but it is quite different. We're doing thousands of different things to millions of different patients every day, and so we rely on people's individual flair and expertise. And our policies must reflect the fact that people have to exhibit those and work within a very varying system. And so in addition to policies, we need to try and make sure that our systems are as safe as they can be, that they constrain people from doing the very bad things and that they help them to do the good things by default, and that we also encourage good individual performance and team working, because the resilience of the system depends on that individual flair and brilliance as well as on constraining bad behaviour. And so Peter's going to talk about how where that puts us in the real world now.
So what Amalberti and colleagues described was this concept of borderline tolerated conditions of use, the real world of work. The table work that you can take back, which we've not had time to let you model here, is an example in a room like this, back in your organization, generating the conversation around the table in regard to, so where are we? How many people are working adherent to protocol, policy and procedure? And how many people are in the real world of work actually working in borderline tolerated conditions of use? Now, what you can see immediately is that if you're working in borderline tolerated conditions of use, you are working outside policy. If you're working outside policy, it's extremely difficult to have that conversation with a management system that has declared to the Healthcare Commission that the organisation is compliant because it has good policy. Are you with me on that? This is fundamental to why the conversation does not flow between busy clinicians and pressed managers. Pressed business administrators worried about the bottom line and worried about the commission are worrying about different things from the clinicians who are struggling to get patient care through in time, online, on budget. And the reality is the manager is not in a position, generally, to tell you about the quality and the safety of the care that you're delivering. That's your responsibility, doctor. That's your responsibility, nurse. And for some of my colleagues, that's turning out to be quite a shock, that if they don't push back and think a bit about how they put speed cameras and police patrols into their areas of work, nobody's going to do it for them. Borderline tolerated conditions of use, the real world of work. This is where I believe the conversation needs to be. Now, the interesting thing about borderline tolerated conditions of use in theoretical terms is we take small steps to get there. We don't all of a sudden go out and speed. We speed incrementally. They are like unregulated PDSA cycles, for those of you who are familiar with Plan, Do, Study, Act cycles. We kind of subconsciously plan and test out. We do speeding. Nothing happens, so we do it again. We speed up a bit more. Nothing happens. The tyranny of small numbers. There is nothing between us and the accident. The second tyranny, the tyranny of paper safety. Think of our commitment to the checklist, to the checkbox. But does it translate into the world of supervision, of observed supervised practice? Do those tick boxes genuinely tell us what's going on between the doctor and the patient, or the nurse at the bedside? So these migrations and violations that we make are seen as benefits with immediate payback. They save time, they increase productivity. There is a tension between following the protocol and getting the job done. This makes people anxious. Tension makes people anxious. Anxiety provokes human error. Just think about it in your own lives when you're overly pressed. So not only is this culture of dissonance, protocol says do it this way, but we actually do it this way around here. Not only does that put a barrier in communication between doctor and manager, it actually creates an anxiety, and that anxiety in itself drives human error. We need to have this conversation, folks, if we're going to start to work back from this rather worrying position. Basically, our organizations are full of tolerated illegal practices which have become stabilized over time because eventually the majority view prevails that we can't afford to go any faster. All stakeholders in the system migrate and violate because our managers are not daft. They know we're cutting corners to get the jobs done. They know we're going at it as fast as the system can possibly can. But they've already made their assurances to the board, and the board has already signed off on compliance to the Healthcare Commission. The system is bought into the dysfunction. So here we go. The breakthrough moment will come when we can acknowledge this state of affairs. It's going to require honesty, openness, and a plan for action. That's about just culture. That's about not hanging and flogging. That's about learning. Of course, what the Americans describe as spray and pray is the standard response to this, which is as soon as anybody violates a protocol, the right thing to do is to send it by email to 3,000 people in your organization and presume that everybody reads their email and that when people read things, that it always translates into coherent action. And then the bottom one. You just have to try a bit harder. You just have to work a bit harder. Pull your socks up, write clearer drug charts. Well, hang on a second. If we thought about systems pressures, there must be something to be understood about why people are scribbling furiously on drug charts in the first place. Take a systems view. Avoid the knee-jerk. We've got to get behind this. We've got to use human engineering, human factors engineering science to really understand the systematic pressures that drive to these stabilized illegal situations. John is going to talk a bit about the real world of work and what we do about this before we have coffee.
So if doing more of the same will get us exactly where we are now, how can we work with this situation where we accept that people are generally working in borderline tolerated conditions of use? Well, first of all, we can surface the problem, and that really means talking to staff and finding out what happens. And as has been said already this morning, there is a reluctance to report events, particularly when they fall in that middle area of not being very trivial and not being very serious. So relying on self-reporting is not going to teach us all that we need to know. You need to go out and talk to staff. We've found leadership walkarounds in our hospital very useful, where we go out on pre-arranged visits to wards and departments to actually talk to staff about how they are working, what they see as being unsafe, and how policies and procedures apply in their departments, to really try and surface the problem and to agree what the limits are with them. And we need to look at our policies and procedures and see if they are fit for the real world. Some hospitals have produced summaries of every policy on a single A4 side. Some have adapted them to individual job roles and said, this is what this policy means to you. So we need to look at both those things first of all. Secondly, we need to acknowledge that there is individual variation in risk acceptance and that we need to change our systems in order to try and improve safety and constrain those individuals who would regularly go outside the accepted limits, but also to help make it easier for everybody to stay within them. To make it easy for people to do the right thing, look at the pressure under which they're working and see what we can do about reducing that, look at the facilities and environment we give them and the systems we design for them to work in to try and make it easy to do the correct thing. Secondly, look at human factors and reliability, change our systems, but also look at the way that people are working together, think about team training, individual training, and how we instruct our staff in the first place in the application of the policies and procedures that we've developed. So look at the human condition. And thirdly, we need to agree with our staff what the actual limits are. What is in the forbidden space? What is the limit beyond which we must not go? And in order to produce that line, we need to have consistency of message. Our junior staff in particular need not only to be told what the policy is, but they need to have it demonstrated to them time after time, day after day, by their senior staff, nursing staff and all their colleagues. So we need to have an agreement between ourselves as to how we apply this policy, what the limits are in our department, and we need to encourage a just culture where people can openly report when things have gone wrong. So to summarise, we know that we work in borderline tolerated conditions of use. Migrations and violations occur. They are frequently unacknowledged, and we need to start having open discussions about what is actually happening. Secondly, it's not always a bad thing that people work in this area of borderline tolerated conditions of use, because individual flair and performance is important in keeping our patients safe in a highly variable environment. But we need to try and manage that area. And thirdly, if we don't, then the situation persists of having this black economy where things are going on that management are aware of but don't openly recognise, and that leaves everybody in a very difficult position, and it makes it impossible to have an open and just culture. So thank you very much.